We will resume again the description of brain tumors on neuroradiological basis. The third group is what is called as cyst and nodule. The first tumor in this group, it's called Biomorphic Xanthoastrocytoma, or simply PXA. Usually we see it in children and young adults. The range is between 2 and 82 years old, but common things are common, children and young adults. It is a peripherally located hemispheric mass, often involves the cortex and the meninges, nearly almost involving the supratentorial system, so it is rarely to report it in the cerebellum or brainstem, rarely found in the cerebellum, spinal cord, retina, and cell. Usually, the tumor is composed of a cyst and enhancing nodule. The nodule is seen abutting the bile surface of the brain. The nodule can be so homogeneous or heterogeneous like this. Okay? So the matrix is composed in more than half of the cases of a cyst and nodule. But as I have described before, any lesion that is composed of cyst and nodule can start initially as just solid nodule. So we can see it as a discrete oval or round mass without a cyst. In CT, it is hypo to hyper to iso. T1 shows hyper to mixed. T2 and the flare hyper to mixed. We can see cysts, calcification is rare, hemorrhage is rare, a strong enhancement or heterogeneous enhancement of the tumor nodule. It is a benign lesion, low grade, so the edema is minimal or absent. One of the features of PXA, when it is like this is a long-standing benign tumor, so it irritates the related meninges, and we can see what is called meningeal thickening or dural tail. Dural tail was described as a common feature of meningioma. It is a sort of proliferation or irritation of the nearby meninges, but actually it is not that specific to meningioma. It can be seen with other tumors that touch the meninges. If you see a meningioma-like lesion like this without cyst and dural tail in young adult, you should think that it may be PXA. Okay? So put in mind that PXA may be associated with dural tail enhancement. In the WHO 2016, another version of PXA, which is called Anaplastic Pleomorphic Xanthoastrocytoma, is more aggressive and less common version of pleomorphic PXA. It is WHO grade 3. It is composed of Anaplastic Pleomorphic Xanthoastrocytoma, which has more worse prognosis. These are examples of the anaplastic PXA. Okay, this is the ordinary one, just nodule like this, and this is the anaplastic pleomorphic xanthoastrocytoma. As you see, it is more heterogeneous and even it shows increased perfusion compared to low perfusion of the benign type of PXA. Also, MR spectroscopy of the anaplastic type is more malignant compared to the benign one. As you see here, there is much more increase of the choline and decrease of NAA in the anaplastic type, while in the benign type, there is milder decrease of NAA and increase of NAA. Also, we can see lactate peaks in the anaplastic one. The second tumor is a famous one called Ganglu Glioma. Ganglu Glioma is the most common cause of a temporal lobe epilepsy. It is a tumor of children and young adults in age less than 30 years. It occurs in all ages, but the peak is between 10 and 20. It can occur anywhere, but most commonly it involves the superficial hemispheres, temporal lobes, with rare locations such as in brainstem, cerebellum, and so on. So it is a lobar tumor that occurs peripherally, and it likes the area of the temporal lobe, and as you see, it is the most common cause of temporal lobe epilepsy. Similar to PXA, it is composed of a cyst and nodule, okay, and the nodule is touching the bile surface. And as I've told you, it may start just as a solid nodule, okay. Usually it is superficially located. It is benign, so it can cause remodeling of the overlying calvarium. We have three patterns, as I have told you. The most common is a cyst and nodule. The second type is just solid tumor. And the third type, which is uncommon and it is not easily to be diagnosed, infiltrative, poorly delineated mass lesion. Again, as I've told you, we can see it just as a solid enhancing well-defined nodule. Or this is the third type, which is large, ill-defined, and actually it is difficult to tell that this is a Ganglu Glioma on imaging basis. We can write a lot of differential diagnosis of such ill-defined infiltrative lesion. Regarding the density and intensities, 40% hypodense on CT, 30% mixed hypodensity with a cyst or isodense nodule. T1 is rarely to be hyperintense, usually it is hypointense. In T2 it is hyper to mixed. We can see calcification because it is a benign long-standing tumor, rarely to see hemorrhage, and as I have told you, the solid component usually uniformly enhanced and may cause meningeal enhancement simulating dural tail, such as in the cases of PXA. A recently described tumor, also called papillary glioneural tumor. It is like Ganglu Glioma, it is cortically based, may be deeply located, usually likes the temporal lobe, with or without calcification, shows enhancement, affecting children, presented by seizures and headaches rarely, indolent course with good prognosis. It is WHO grade 1 and recently described tumor called papillary glioneural tumor. Okay, it more or less simulates Ganglu Glioma. These are the summary of the papillary glioneural tumor, and as we have described, it is a newly described tumor in the WHO 2016. The next tumor is Binocetic Astrocytoma. 80% occurs in less than 20 years old, in age older than that of medulloblastoma. It likes the area of the cerebellum, 60%, then the optic nerve chiasm in 30%, and it can also occur in the brainstem. I think we have described one of them, which is mesencephalic tegmental astrocytoma, okay, brainstem astrocytoma, focal tegmental glioma. Overall morphology often determined by cystic component, while when it involves the optic nerve, usually it is solid and causing it to elongate and got thickened, giving buckling of the optic nerve, or what is known as dotted eye appearance. It is hypo to iso dense in CT, T1 hypo, T2 and flare hyper, calcification at 20%, rarely to see hemorrhage, more than 95% in hands, 50% show non-enhancing cyst and strongly enhancing mural nodule, 40% just present as solid with necrotic center, and this is very important to realize. It can simulate glioblastoma multiforme, and we will explain this in the coming slides. In 10% it is only solid, just solid lesion, and the cyst may accumulate contrast on delayed image. The cyst wall usually enhances. This is a benign tumor, so there is little or no tumor. As you see, the most common pattern is cyst and nodule. Okay. Sometimes it starts just as a solid nodule like this. Okay. And when it affects the optic nerve, it is solid like this. And this is what is meant by dotted eye appearance due to buckling and tortuous course of the optic nerve. You can see as the italic letter I appearance, okay, due to enlargement of the CSF spaces also around the optic nerve. And this is the most serious appearance that makes a lot of conflict, is when the tumor got central necrosis simulating glioblastoma multiforme. Okay. The problem also is that the MRS of Pyrocytic Astrocytoma, in spite it is a WHO grade 1, is very aggressive appearing, very high choline, low NAA and creatinine, and sometimes you can see other metabolites of denoting malignancy, such as lactate. So in children, if you see glioblastoma-like lesion in the posterior fossa, even with a high aggressive MRS curve, you should think that it may be Binocetic Astrocytoma, okay, which is much more benign. Put this in your mind when you deal with necrotic ring-like lesion like this in the posterior fossa in young adults and in children. Okay, let us see the solid component of Pyrocytic Astrocytoma. Okay, is hypoperfused and the curve is malignant. To be compared with the solid component, okay, in high-grade tumor, high-grade astrocytoma, it is hyperperfused. So we can use perfusion-weighted imaging to differentiate this low-grade from high-grade tumors, which are almost presenting by the same appearance of necrotic ring. This paper, our colleagues in MD section can read comparison of perfusion, diffusion, and MR spectroscopy between pilocytic astrocytomas and high-grade astrocytomas. Hemangioblastoma. Hemangioblastoma can be seen as sporadic or familial or syndromatic, familial syndromatic in von Hippel-Lindau syndrome. Sporadic hemangioblastomas occurs in elderly, 40 to 60 years old, but familial, which occurs within von Hippel-Lindau syndrome, can be seen in young age. Okay. The most common location is the cerebellum. It is seen in 80%, while 20% are seen supratentorial around the optic pathway. And of course, you know, if we find one hemangioblastoma, we should seek for other early evolving hemangioblastomas along the whole neuro axis, including the spine and the rest of the brain. The matrix is usually solid and nodule, as we have described, but also it can start as just solid, okay, in 40%, 60% solid and nodule and cyst, and sometimes we can see it as just cyst like this. So these diagrams are more or less describing the different patterns of presentation of hemangioblastomas. From the name hemangioblastoma, the nodule is very hypervascular, so it can bleed into the cyst. So we can see hemorrhagic changes within the cyst. In addition, we can see a nearby feeding vessel, okay, supplying this hypervascular nodule. We use these items when reviewing the image to suggest hemangioblastomas. Of course, because it is highly vascular, it enhances markedly, and we can see a nearby signal void due to high. Sorry for this interruption. Again, these are the three patterns. It could be solid and nodule, or cystic like this. Let me give you a tip. If you find a cyst and nodule in a cerebellum in a child, it is Binocetic Astrocytoma until proved otherwise. If you see the same picture in an elderly, hemangioblastoma is the prime consideration. Of course, there is a list of differential diagnoses, but common things are common. Cyst and nodule in childhood is astrocytoma, pilocytic astrocytoma. Cyst and nodule in elderly hemangioblastoma is the prime consideration. Again, as a rule, if you find one hemangioblastoma, you should screen the rest of the neuroaxis for others. And sometimes they may do conventional angiography or DSA to detect tiny enhancing nodules that is not yet visible by MRI. Astroblastoma. It is a rare tumor. It can occur at all ages, but as we teach, when you see the word blastoma, it means that we are dealing with the children and young adults. Okay. Usually it occurs in cerebral hemispheres, typically superficial in location. It likes the area of corpus callosum, cerebellum, optic nerves, brainstem, but usually it is seen as a peripheral lobar lesion. It is composed of a cyst and nodule, but the nodule has the characteristic appearance of being bubbly. You remember central neurocytoma, bubbly appearing lesion? The solid nodule is bubbly because it contains multiple tiny cysts, and the cyst wall is enhancing. The solid portion may be mildly hyperdense on CT, and we can see punctate calcification, and the solid component shows the bubbly appearance in T2. Edema is usually minimal or absent. Enhancement is heterogeneous, in addition to enhancement of the cyst wall. This is a rare tumor called astroblastoma. Desmoplastic infantile Ganglu Glioma. From the name, desmoplastic, as if it is creating fibrotic reaction. Infantile, so we will see it only in infants. Ganglu Glioma, it It is similar to Ganglu Glioma. It is composed of cysts and nodule. It is called DIG or DIGG or Desmoplastic Infantile Astrocytoma. It is mostly seen during infancy, usually children less than 24 months, rarely to be seen in older ages, usually affects the cerebral hemispheres. It likes the region of the frontal more than the parietal and temporal region. It appears like this: lesion, cysts, and nodule. Okay, cyst and nodule. The nodule appears hypointense in T2. Hypointensity in T2 means that it is highly cellular or fibrotic. From our practice in MRI, the things that appears hypointense in T2 is fibrotic. So the name is called desmoplastic, hypointense. And it will smoothly, homogeneously enhance. And as you see, you can see dural tail here because of it. It is a long-standing benign tumor. The cyst is large like this, and it is surrounded by extensive vasogenic edema. Usually we don't see calcification, and we don't see hemorrhage, and this explains that the low signal in T2 is due to high cellularity, or what is called the desmoplastic reaction. Desmoplastic infantile Ganglu Glioma. Sometimes, you know, schwannomas. Schwannomas are the tumors affecting the cranial nerves and peripheral nerves. Okay, 70% of intraparenchymal schwannomas present before the age of 30 years old. Okay, typically cranial nerves schwannomas are seen involving the 8th cranial nerve, vestibular schwannoma. It may affect trigeminal nerve and so on. Sometimes the schwannoma originate inside the brain itself, intracerebral, and this is rare. Okay, and when it is presenting there, it presents as a cyst and nodule. See, it presents as a cyst and nodule as if it simulates Ganglu Glioma or PXA or Binocetic Astrocytoma. Don't be astonished if the biopsy returns to you that it is a schwannoma. But the classic teaching that it affects the cranium. And these are examples. Okay, this is the V1 branch, okay, of trigeminal nerve schwannoma. Trigeminal schwannoma, it could be solid like this or may got necrotic in its core, but the orientation along the course of the trigeminal nerves make this diagnosis. We can see it involving the cerebellopontine angle, acoustic schwannoma, giving the ice cream cone appearance, and sometimes it can be associated with cyst, tumor cyst, or acquired arachnoid cyst surrounding this tumor. This is the classic teaching, but the previous slide shows that it can originate inside the brain, intraaxial, presenting as a cyst and nodule. These are other schwannomas. This one is along the oculomotor nerve. This is correct. Again, this is along. This course is of what? Usually this is trigeminal schwannoma. This one along the trochlear nerve, the 4th cranial nerve course. You can see enhancing tiny lesion like this. This one is along the abducent nerve. And these are along the 9th and 10th cranial nerves, schwannomas. And this one is along the hypoglossal nerve. It takes the whole course of the hypoglossal nerve down to the hypoglossal canal. Now we will discuss the 4th group, which is diffuse or infiltrative tumors. The first one is diffuse astrocytoma or low-grade diffuse astrocytoma. It can occur in any age, the majority between 20 and 45. 2/3 are supratentorial, 1/3 is infratentorial. Usually it affects the white matter, but may extend to the cortex. 20% of these diffuse astrocytoma may originate in the thalami or in the basal ganglia. The matrix is ill-defined, homogeneous, and may appear well circumscribed in early stages. Iso to hypo 3T, T1 hypo, T2 undeflared hyper, cysts are uncommon, calcification in 20%, hemorrhage is rare, enhancement is rare. Usually, if we see enhancement in a glioma, it is not low grade. Edema is rare, the diffusion it is not restricted, and the perfusion usually it is of lower relative cerebral blood volume compared to the anaplastic or glioblastoma multiforme. Usually we see a lesion like this, ill-defined or well-defined, causing expansion of the gyrus, okay, to differentiate it from infarction. And usually it doesn't take the territory of a certain vessel. It can be seen non-territorial in its distribution. For example, this lesion as if taking the territory of middle cerebral and anterior cerebral, and it is causing expansion or enlargement of the affected gyrus. And this is another one much more well-defined. These are the different appearances of diffuse astrocytoma. It infiltrates the gray matter, causes expansion like this, ill definition of its border, the edema is minimal, and here as you see there is expansion of the affected gyrus. This is the clue that allow us to say that it is neoplastic, not just inflammatory or vascular insult. Astrocytoma, as you know, it is a spectrum from low grade to anaplastic to malignant one or grade 4. The anaplastic astrocytoma is grade 3 glioma, WHO classification. It can occur at any age from 40 to 50, usually affecting the hemispheric white matter. In children, it may involve the bones or the thalamus. Less commonly, it may involve the brain, stem and spine. It appears as ill-defined, infiltrative, heterogeneous, and may appear well circumscribed, hypo, dense in CT, T1 hypo to iso, T2 undeflared hyperintense, uncommon to see cysts, calcification rare, hemorrhage is rare, enhancement, the majority doesn't enhance, but if you see enhancement in a gliomatous lesion, you should think that it is not low grade. It can be anaplastic or high grade. Rarely to see edema. The diffusion is not restriction. The perfusion, it is more hyperperfused compared to low grade. You can see prominent signal voids due to increased vascularities. And MRS, of course, we see non-penile curve, elevated choline-creatine ratios, decreased NAAA, and decreased myoinositol per creatine ratios compared to the low-grade astrocytoma, which shows increased myoinositol creatine ratios. As you see, ill-defined lesion that infiltrates and expands the affected structure. Sometimes we can see enhancement lesions. On the extreme, and this is very important, glioblastoma multiforme. It is WHO grade 4 glioma. It can occur at any age, but usually, or the majority, is seen in elderly. It is a tumor of the elderly, 50 to 70 years old. Usually affect the supratentorial white matter, but we can see glioblastoma multiforme anywhere of the brain. It is ugly looking tumor, aggressive looking tumor. When you see it, usually you will not miss it. Ill-defined infiltrative lesion that is surrounded by extensive vasogenic edema. It likes to involve the midline structures, and sometimes it involves the corpus callosum and go to both cerebral hemispheres. This is what is called butterfly glioma because it bihemispheric in its extension. The most important thing is the pattern of enhancement. The pattern of enhancement, which is called necrotic ring pattern of enhancement, which is similar to abscess. Necrotic pattern of enhancement where there is peripheral irregular enhancement with evidence of thread-like enhancement within the core of the lesion due to central necrosis. This pattern is more or less very specific to glioblastoma multiforme if you see it. But actually you can see a lot of patterns of enhancement being heterogeneous or even sometimes solid or nodule or patchy or ring-like, but the very characteristic pattern of necrotic ring pattern or peripheral irregular enhancement is specific to glioblastoma multiforme. Of course, it is aggressive tumors, so the edema is extensive and the mass effect is extensive, and it can also be associated with intracranial CSF seedlings similar to those of medulloblastomas, diomas. The clue that we use to differentiate ring-enhancing lesions, whether it is tumors or abscess, we use the perfusion and the diffusion-weighted imaging. Usually in abscess, the core is restricted while the periphery is not. But in glioblastoma multiforme, the peripheral enhancing portion is restricted because of high cellularity. Also, in perfusion, the wall, which is enhancing, is not hyperperfused, but the solid component in glioblastoma multiforme is hyperperfused. So these are the tools in our hands if we are confused whether this is an abscess or glioblastoma multiforme. We use perfusion-weighted imaging and diffusion-weighted imaging to differentiate abscess from glioblastoma multiforme. If you see thick, irregular, enhancing, rend neoplastic tissues surrounding a necrotic core in elderly, please think that it could be glioblastoma multiforme. Again, this what we have described. This is an abscess. The core is restricted, while in glioblastoma multiforme, the wall is irregular and shaggy like this, and the wall restricts while the core is not restricted in diffusion-weighted imaging. Glioblastoma multiforme have some rare patterns of growth, but is pathognomonic. This one of it, periventricular, you see lesion like this infiltrating the periventricular or the subependymal tissues. Okay, this pattern can be seen in many diseases. Number 1, glioblastoma multiforme. Number 2, lymphoma. And number 3, in metastasis. Number 4, in inflammatory or ventriculitis. But in ventriculitis, the patient is feverish and you see just thin wall of enhancement, not a rend of tissues like this. The other thing that glioblastoma multiforme, it can present as multicentric like this, simulating metastasis, and this is a dilemma. You can see multiple lesions in the same time or one after the other representing multicentric glioblastoma multiform. In the WHO 2016, they added a new version of glioblastomas called epithelioid glioblastomas. Have a predilection for young adults and children, sometimes coexist with pleomorphic Xanthoastrocytomas, usually affects the midbrain or less frequently the superficial hemispheric mass. Hemorrhage and leptomeningeal seedling are probably fairly common at the time of diagnosis. These tumors are indistinguishable from the glioblastoma on imaging, with enhancement, necrosis, and diffusion restriction presenting in the vast majority of tumors. Now, entity called Glioblastoma Gliomatosis cerebri. Before the WHO 2016, that it was a specific entity described as a tumor by itself. But now they consider it a pattern of growth. Gliomatosis cerebri previously was considered as a low grade, WHO grade 1 to grade 2, but now it can occur from grade 1 to grade 4, but it is a pattern of growth. What is meant of a pattern of growth? There are criteria to tell that we have gliomatosis cerebri pattern of growth of glioma. Typically affects hemispheric white matter with involvement of the overlying cortex. It can occur at any age, but most commonly in the 40s to 50 years old decades. The criteria: there should be 2 or more lobes affected. In addition to lobes plus basal ganglia or thalami, corpus callosum, brainstem, spinal cord affection. Gliomatosis cerebri may cross the corpus callosum or the massa intermedia and infiltrate the 2 cerebral hemispheres. And the other criteria, which is very important, that it causes enlargement of the affected site, but it maintains its brain architecture. What is meant by this? It causes expansion, but maintaining the shape, as if it is benign infiltrative lesion causing enlargement without distortion or destruction of the shape of the structure, and we will see thus the coming images. This is a pattern involving the frontal, temporal, corpus callosum, okay, and the basal ganglia. Here, involving the temporal lobe and the brainstem. As you see, it causes expansion. It causes expansion. Here, it is involving the bones and the cerebellum. It causes enlargement and expansion of the affected site. The tissue matrix is usually homogeneous, poorly defined, asymmetric, low density in CT or hyperintensity in T2. Sometimes it may be totally normal. It causes expansion, but with mild mass effect and mild effacement of the sulci and the ventricles. We see it as hypo to iso in CT, hypo to iso in T1, T2 and the flare hyperintense, no cyst, no calcification, no hemorrhage. Usually we don't see enhancement. If you see enhancement in this pattern, it means that it is of high grade or it shows malignant degeneration, no edema, no restricted diffusion. Actually, this is the appearance in CT, and this is the appearance in T2 of the brain, in the flare of the brain. As if it is simulating white matter disease of elderly arteriosclerotic leukoencephalopathy. But as you see, it is not bilateral, symmetrical, and there is some expansion of the corpus callosum here and it goes to involve the subcortical white matter. This ugly appearance may raise the possibility of gliomatosis cerebri, not just ischemic white matter disease. Again, enlargement, okay, expansion of the thalami. If you see enhancement, it means that it is not of low grade. Here, the basal ganglia and thalami are expanded. Here, the brainstem and the frontotemporal lobes white matter are infiltrated by the gliomatosis cerebri. One of the clues to diagnose gliomatosis cerebri when it is low grade is the presence of high myoinositol peak. Okay, myoinositol peak, which is a marker of gliosis due to long-standing benign nature of this lesion. In addition to that, it is hypoperfused, not hyperperfused. If we want to compare it with lymphoma, it is hypoperfused compared to lymphoma. And in MRS, we can see myoinositol peak and short TE, which is a marker of gliomatosis cerebri. The key is T2 hyperintensity lesion with enlargement of the involved structures in elderly with multiple lobe in addition to basal ganglia, thalami, and brain stem affection. Now to two tumors called the oligodendrogliomas. We have oligodendrogliomas of low grade and anaplastic oligodendroglioma. Regarding the first one, low-grade oligodendroglioma, the peak age is in the 40 to 50 years old, but can be seen in any age. Typically involves the subcortical white matter and the overlying cortex. It is one of the peripheral or apparently cortically based lesion. The majority, 85%, are supratentorial. The most common site is the frontal lobe. Usually it likes the frontal lobe. Oligodendrogliomas may mimic cortically based masses such as Dennett, although these typically occur in younger patients. Oligos cannot be reliably differentiated from anaplastic oligodendrogliomas on imaging alone. It is difficult. Oligos are most common intracranial tumor to calcify, and this is the clue. If you see a neoplastic lesion involving the periphery of the cerebral hemisphere with calcification, this is oligodendroglioma until proved otherwise. The most common tumor to calcify. As you see, you will find glioma-like lesion causing expansion like this, and in addition, you can see calcification in CT or in SWI. Don't miss this. If you see calcification, oligodendroglioma is the primary consideration. Infiltrative mass that appears well demarcated early, 20% may show cysts. Calcification is seen up to 80% of cases. Hemorrhage is uncommon. Enhancement is heterogeneous. You can see also dural tail with it because it is a benign long-standing lesion. Uncommon to see edema, uncommon to see restriction. These are the patterns of calcification. Here CT is superior than MRI in detection of the calcification. It can be so ugly looking calcification or just nodular or linear like this. Again, calcification in a tumor is oligodendroglioma, and this is SWI, which is very helpful in detection of intracerebral hemorrhage or calcification. And I think you know how we can differentiate calcification from hemorrhage using the SWI, its magnitude and phase image. We compare according to the system. Usually the calcification can give low signal or pluming, okay, while in the phase image it gives hyper intense signal. This is in the system which is called right-handed magnets. Sometimes in the left-handed magnets you see pluming of calcification, black in the image of SWI and black in the image of the phase images. To help you easily, take the internal cerebral veins as a reference, okay, to differentiate hemorrhage from calcification. Look here, calcification is black and the internal cerebral veins are black, okay? But in the phase image, the calcification here is white or black like this. I'm not sure the image is that heterogeneous, but it appears black here, while the internal cerebral veins are appears bright. Actually, I can explain this phenomena much more better in other cases, because I think there's some confusion here regarding the system. Sorry for this inconvenience. Oligodendrogliomas, even the low-grade one, are hyperperfused on cerebral blood volume and blood flow. And this is an important point. This is the benign tumor that is hyperperfused, and perfusion-weighted imaging cannot be used to differentiate benign or low-grade oligodendrogliomas from high-grade oligodendrogliomas. Many gliomas may mimic anaplastic oligodendrogliomas. The presence of calcification, cortical expansion can help to differentiate oligodendrogliomas from other gliomas. Also, as I've told you, it is not easily to differentiate benign or low-grade oligo from anaplastic oligo on imaging alone, even using the cerebral blood volume, because the low-grade one is hyperperfused. The counterpart is the anaplastic oligodendroglioma, or what is called high-grade oligodendroglioma. It occurs in elderly also. The mean age is about 50 years old. It is WHO grade 2. It appears as supratentorial hemispheric mass, involve the cortex and subcortical white matter. Usually it lacks the frontal lobe. It may erode the calvarium, and it may involve the parietal and occipital lobes, and usually it expands the overlying cortex. It is more or less similar to oligodendroglioma, but it appears more aggressive. It may be surrounded by extensive edema. The enhancement may be that heterogeneous. And of course, the same pattern, up to 90%, may show calcification. Supratentorial primitive neuroectodermal tumor, which is called S-Bennett or supratentorial Bennett, and some people called it ganglioneuroplastomas or primary cerebral neuroblastoma. It affects the supratentorial region, and as we have explained before, it is a tumor of infants and young children. Once you see neuroectodermal or blastoma, you think that it is of children, infants, and sometimes in young adults. It is a cerebral embryonal tumor composed of undifferentiated neuroepithelial cells, which have the capacity for differentiation to astrocytic, ependymal, neuronal, muscular, and melanocytic or melanotic cells. It is more common in young children. The median age at diagnosis is 35 months. It can affect the hemispheres, the pineal, the cortical, subcortical, thalamic, and supracerebral. Usually we see it as a large mass, ugly looking like this. It may be solid, and cystic. It may show enhancing nodules, or it may be associated with CSF seedlings like this. This is leptomeningeal enhancement. In spite of this large size of tumor, usually it is surrounded by minimal or absent peritumoral edema, and this is characteristic for this tumor. Okay, if you remember, in infancy we can see DIG, desmoplastic infantile ganglioglioma, and it was composed of cyst and solid component, but the solid component was hypointense in T2, but here it is more or less hyperintense in T2. These tumors are surrounded by minimal or absent edema, while in DIG it is surrounded by extensive edema. Because of high cellularity, the solid components are restricted in diffusion, and this tumor, of course, is liable to CSF seedlings. Okay. You remember atypical teratoid rhabdoid tumor? This is a very malignant tumor that we can see in infancy up to the age of 3 years old. It simulates medulloblastomas in its imaging features, and it can affect any areas. It can be seen intraventricular or within the cerebral white matter, basal ganglia, supratentorial, cellular, and so on. So it is aggressive tumor that can be associated with CSF seedlings. It is a malignant rhabdoid tumor of the brain, rare aggressive tumor, and the clue here is the age, usually age below 3 years old. 50% infratentorial. It can affect any area as we it can be intraventricular, cerebellum, cerebral. It can show calcification, hemorrhage. The solid component is restricted in diffusion. The MRS is very aggressive curve, surrounded by extensive edema. It may contain calcification, hemorrhage, surrounded by extensive edema, and because of high cellularity, as I've told you, usually it is hyper-attenuating in CT and hypo-intense in T2. These are the different appearance of atypical teratoid rhabdoid tumor, and as you see, it is more or less simulating medulloblastoma. Again, it is involving here the frontal lobes, simulating glioblastoma multiforme, okay, irregular ring, necrotic pattern ring of enhancement, but the age here is the clue. This one is very important, primary CNS lymphoma. Okay, primary because it is not secondary. What this means? It means that the first diagnosis of lymphoma is in the central nervous system with no lymphoma elsewhere in the body that it is metastasizing to the brain. Usually it is B lymphocyte lymphoma, and steroids may have dramatic effect on imaging and biopsy results. It may melt with steroids, so take care that steroids can change the biopsy results. Primary CNS lymphoma is seen in 2 categories of patients according to the immunity status. It can be seen in immunocompetent, and in this situation we see it in very elderly, 6th to 7th decade. Or it can be seen in immunocompromised patients, especially AIDS. It can be seen in adults or in children. So we can see it at all ages. Supratentorial affection is seen in about 80% of cases. It likes the mid-like structures. It likes the corpus callosum, periventricular white matter, the basal ganglia, the thalami. These are the favorable sites that lymphoma likes to affect. Frequently, it can be seen along the ependymal surfaces, or rarely it can be seen in the cellular and pineal region. And of course, lymphoma can involve the dura, especially if it is metastasizing from elsewhere. But In primary type, usually it involves the brain parenchyma. These are the sites. It likes the midline structures, basal ganglia, corpus callosum, thalami. Okay, and remember this appearance, subependymal or ependymal lining simulating glioblastoma multiforme and the basal ganglia. There are two types of lesions according to the immune status. If the patient is immunocompetent, lymphoma becomes as solid nodular lesions. But if the patient is immunocompromised, it comes with the pattern of ring-enhancing lesion. Okay? Because of high cellularity, it will appear hyper to iso-dense on CT, T1 hypo-intense, T2 iso to slightly hyper-intense in T2, and it will show restricted diffusion. Calcification may rarely be seen actually after therapy, after chemotherapy, not before. Hemorrhage is rare but can be seen in immunocompromised patients. As I've told you, two patterns of enhancement: solid enhancement in immunocompetent and ring-like in immunocompromised patients. This is a typical affection of the brain. Lesion involving the splenium of corpus callosum, showing restricted diffusion and enhancement. Lymphoma should enhance. Okay, this is very important. This is not infarction. This is lymphomatous infiltration. Again, this is the pattern, ring pattern of enhancement in immunocompromised. Okay, core of necrosis. But usually the solid pattern is seen in immunocompetent patients. Some rare tumors that have been added to the WHO 2016, what's called as extraventricular neurocytoma. You remember intraventricular neurocytoma? It is the same but affecting the parenchyma as diffuse lesion, typically seen in children and young adults, but it can be seen up to 76 years old. It is WHO grade 2. Like the intraventricular, it is affecting the cerebral hemisphere, and it can be large, heterogeneous, with cysts and hemorrhage and calcification with diffusion-weighted imaging. It is the same pattern, but involving the cerebral hemisphere, not the intraventricular compartment. Again, this is publicly appearing lesion, extraventricular neurocytoma with calcification. Again, calcification and hemorrhage. Okay, the solid component is enhancing, may be surrounded by vasogenic edema. Actually, it is difficult to tell in this patient that it is extraventricular neurocytoma. We can write it as high-grade glioma, ependymoma. So a list of differential diagnosis is better to be used in equivocal cases or cases with similarities like this, but don't be astonished if the biopsy results come that it is extraventricular central neurocytoma tumor. A recently described variant of astrocytoma called Biomorphic Astrocytoma. It was initially a variant, but now it is considered in the WHO classification as a grade 2 WHO. Usually it is seen in young adult or children, more aggressive in behavior than Pyrocytic Astrocytoma. Usually it likes the area of the hypothalamus and the chiasmatic region, but it can be seen in the thalamus, cerebellum, and so on. But this area is very characteristic, hypothalamic chiasmatic region. The lesion appears as a supracellular mass that infiltrates the hypothalamus and the chiasmatic region. It is seen as if it is cystic because it appears very bright in T2 and the FLAIR, okay? But after contrast administration, it avidly enhances. This is very characteristic for this lesion. It appears as if it is high proteinaceous cystic lesion, but with contrast, it avidly enhances, and it likes this area, hypothalamic chiasmatic region. This is what is called Biomorphic Astrocytoma. It may involve the cerebral hemisphere and may show hemorrhage inside, giving the fluid levels like this. I will stop here, and in the next lecture we will continue the other groups. Thank you very much.